Welcome to Schizophrenia, a promising treatment era dawns. My name is Christoph Correll. I'm professor of psychiatry and molecular medicine at the Zucker School of Medicine at Hofstra, Northwell in New York, and also professor and chair of child and adolescent psychiatry at the Charité University in Berlin, Germany. I'm joined today by Professor Meyer, who is a clinical professor at the University of California, San Diego. Welcome, Jonathan.
Thank you, Christoph. Great to be here.
So today's program is actually titled Improving Patient Outcomes. What are the beneficial and potentially clinically relevant adverse effect profiles of antipsychotic agents for schizophrenia? So in other programs, we are focusing on the future of antipsychotic treatment in schizophrenia. Today, Jonathan will review what we have in our hands right now. So maybe we can start with the efficacy advantages that the current postsynaptic dopamine modulators actually have.
Well, to be honest, I don't think we realize how much of a revolution they were 70 years ago. Before that, we really had nothing. There was an old drug called reserpine, which modulated presynaptic dopamine release, but was very poorly tolerated. I think we would say dopamine blockade or perhaps dopamine partial agonism at the D2 receptor has been very helpful. It's allowed some people to do quite well. But as we will talk about, there are limitations of postsynaptic D2 receptor modulation. But for those who respond and who tolerate it, it has allowed them reduction in their positive symptoms. But I think as we realize, Christoph, schizophrenia is not just positive symptoms. Am I right?
Correct.
Yeah, and that's been the issue. Yeah, go ahead.
Yeah, exactly. And so we have positive symptom improvement, but also not in everyone, correct? So there is a subtype of schizophrenia where this postsynaptic modulation may not be good enough. Maybe there's too much presynaptic output or other receptor systems are involved.
Yeah, absolutely. I mean, we now have imaging studies which show that there are many people who are treatment resistant, which is probably roughly at least a quarter to 30% of the schizophrenia population for whom all the D2 modulation is not going to help them. They may have abnormalities in certain circuits involving glutamate, and some of this is actually remediated by using that special medication clozapine. But we certainly understand that for a good fraction of people, dopamine D2 receptor modulation does not solve their positive symptom problems. And as I sort of alluded to, we don't have really anything that improves cognition, and we have somewhat limited options for negative symptoms. I mean, what would you tell the clinicians if they say I have a patient with negative symptoms? What would you suggest for them?
Well, I mean, we've seen that maybe some partial agonists could help somewhat. We also have obviously psychosocial stimulation, but the primary negative symptoms may not improve. We want treatments that don't cause too much sedation or extrapyramidal side effects. And maybe that brings us to some of the downsides of the current dopamine receptor modulators. So what are the side effects that we're dealing with?
Well, it really is a two-edged sword. The thing that was helpful also has its downsides. D2 receptor modulation, as most of us know out there, can cause D2-related adverse effects. The classic ones, of course, are neuromotor, Parkinsonism, akathisia, dystonia, tardive dyskinesia. There's also peripheral endocrine adverse effects from D2 modulation at the beta cell level, and a study published last year showing that that same thing can happen centrally when you infuse antipsychotics intraventriculaarly. We also see impact on glucose insulin homeostasis. So we have a lot of downsides. And then lastly, of course, the classical endocrine adverse effect of hyperprolactinemia. And so while D2 modulation is good, but there is a price to pay for that. And as you also allude to, these drugs are not just pure D2 modulators, they have other monoamine binding profiles. H1 blockade, sedation and weight gain, alpha-1 blockade, orthostasis. If you're unfortunate to have a molecule which has a lot of muscarinic antagonism, you have the peripheral adverse effects, and also the central one as well. Anticholinergics centrally don't make you any smarter, do they?
So that's cognitive disability that might be enhanced. And then also we might have dry mouth and constipation, which can be problematic with the current agents. But I mean, you are talking about profiles that don't cut across all agents. So we've seen a refinement of these medications with less and less side effects, but most of them have at least one of those, correct?
Yeah, there's no free lunch in psychopharmacology. As you said, we've improved tolerability. So going from first generation to second generation, we've been able to moderate the D2 related adverse effects. They're not absent. The latest meta-analysis says still the TD rate in people only on second generations with chronic use is 7.2%. That's a fourth of first generations, but it's not zero. The serotonin 2A antagonism or partial agonism helps mitigate some of these D2 related adverse effects. There's very few compounds which will ever be released in the future which have a lot of histamine H1 or muscarinic antagonism. Those are mostly absent now from newer agents, as is alpha-1 blockade. But the one thing we haven't improved upon over the last 30 years of second generation agents is efficacy. Clozapine still stands supreme for treatment resistant, and even the successor, the first approved second generation agent widely used, risperidone, which was approved in late 1993 in the US, nothing generally has been approved since then, which is dramatically more effective, unfortunately.
Yeah, that's very true. And obviously, clozapine comes with a lot of side effect baggage, even more than the other agents. And what we also have a problem with is that there are people who are not even responding to clozapine. So we may need to tackle the illness in a different way. And that's where we will talk in other episodes about the future that dawns, modulation of dopamine in a different way via different receptor profiles, and maybe even glutamate, which you also alluded to. Well, thank you very much, Jonathan. This was great to tell us where we are at right now, where we're starting, and what we need to improve upon. Thank you very much for listening, and we hope that this was helpful.